Okay. So, good morning, everybody. This is the week immediately after our annual IHRS conference at Delhi. I am Dr. Ashish Nabar. I am the coordinator for this IHRS DMDNB arrhythmia teaching program, which has definitely been a success in terms of the consistency with which the IHRS faculty has appeared on it, and we have presented it, involved a good number of centers from all over the country into this program. What is an unfulfilled wish from my side is to have more and more attendees on this program. Traditionally, there are about 1,500, I guess, cardiology postgraduates if you count all the 3 years training in India at any given time. And I'm sure there are a lot more who can benefit by joining us. This program is heavily backed by the IHRS Executive Committee led by its president, Dr. Ullas Pandurangi. And this year we have been lucky to have Sun Pharma being kind to us to provide the platform and all the logistic support. But by and large, a big thank to the IHRS faculty from different academic as well as academic departments in the country, as well as private hospital settings, which have a big workload. And they have all always willingly agreed to make a presentation sticking to a particular theme. Also, we have good moderators from cross zones who have agreed to make this program more purposeful. So this time we have Dr. Anunay Gupta, who's taken the lead to from VMMC Delhi, who has taken the lead to construct a program on ventricular tachycardia, ventricular arrhythmias, and he's involved the faculty from his department, including Professor Isar, Dr. Ankit Jain, and Dr. Gaurav Arora. And I'm sure we'll have a good learning through the next 2 hours. So be there through the whole length of this program, and I think it should be we should find a Sunday morning spent in a worthwhile way. So Anunay, if you can introduce your faculty, and then we can request Professor Isar to start his presentation.
Uh, Hi, good morning, everyone. First of all, I will thanks Dr. Ashish to consider us for this arrhythmia teaching program, which is being run by our IHRS society. And I would like especially thanks my colleagues and my seniors in the department who help us to build up this 4 topics for DMB students. And first of all, Professor Issa will present localization of idiopathic VT, followed by Dr. Gaurav and Ankit sir and me. And I think we can let Dr. Issa sir to start.
Yeah, certainly. Dr. Isar, if you can share your screen, and we can start with your presentation.
Yes, sir. So is my screen visible?
Not yet.
My slides are not visible?
No, I think share screen again.
I do that. I'll do that.
So just to introduce the moderators in the meanwhile, Dr. Deepak Padmanabhan is a faculty at the Jayadeva Institute in Bangalore, again a very high volume center. And Dr. Deepchand Raja is a very reputed and a very learned electrophysiologist from Chennai. So I think they will bring in their inputs and very nicely keep this program to its purpose, that is to train some of our cardiology trainees across the country. Yeah, Dr. Isar, we can get on.
Yeah, is my screen visible now?
Yes, yes, you can go on presentation. Yeah, perfect.
Yeah.
Still, I think presentation mode. Yeah, that's it.
It's okay, sir?
Yes, perfect.
So,
we are ready.
Good morning, all attendees and all faculty members. Presentation designed today is for VT. So my topic is ECG localization of idiopathic VT. I will stick to the idiopathic VT only because this structural heart disease and ischemic heart disease, VT localization is different than the idiopathic VT localization. And I'll try to keep it to the basics because attendees and students are DMB students only. So I'll try to be as simple as possible. So this is idiopathic VT occurs in structurally. I'm audible and slides are visible. I just confirm it again.
Yes, very much.
Okay, thank you, sir. So idiopathic occurs in VT occurs in structurally normal heart, and most of them, 70%, arise from outflow tract. Surface ECG is useful for localization before we plan for further evaluation, further medical treatment or ablation procedures. So ECG has its own importance still today when EP has advanced to great extents. So this is a full spectrum of idiopathic VPCs, NSVTs, and VTs, and they can be effectively treated with some with drug therapy and all of them with catheter ablation. So PVC localization from ECG may provide clues to underlying cardiac disease. It may help in medical therapy because some types of VTs are preferentially responsive to different types of drugs and may help in knowing relative risk and effectiveness of catheter ablation and for planning of catheter ablation procedure. So this is the very basics of ECG, which every student should understand and fully remember all these things. Because localization depends on all these things only. So basic understanding of vector ECG cardiography and axis deviation and lead placements. So this is lead one, right arm, left arm. Left arm is the positive pole of lead one. Lead two positive pole is lower. Lead three positive pole is left limb. So AVR, AVL, and AVF positive pole on right, left, and fit side respectively. And this is a normal axis from minus 30 to 90 is the normal axis. Superior axis is the left axis, minus 30 onwards, and this is the right axis, right inferior, and right superior axis. So this all helps in localization of VT. So this is the very basic which we should keep in mind. So QRS axis, superior oblique inferior, and right left axis, bundle branch block pattern. Precordial transition is very important in localization of VT and further localization, minor localization and finer to the point localization, precordial transition, QRS weight. It is septal versus free wall. Septal focus produce a narrow QRS complex because it is synchronous with ventricular activation, and free wall, both right and left, they will produce wide QRS because of sequential ventricular activation. So base versus apex, base is consists of tricuspid and mitral annulus, structures near tricuspid and mitral annulus. So RS ratio in lead V6 tells us about base versus apex localization. So what are the relevant ECG features for localization is QRS width, narrow QRS, as I have already explained, septal, and one more epicardial VTs are wide QRS complex. Epicardial VTs produce pseudo delta wave, intrinsicoid deflection time, maximum deflection index, and RS complex are short RS complex. Shortest RS complex is more than 121 millisecond in epicardial VT. So this is intrinsic deflection time. This is pseudo delta wave is the initial slurring before the sharp upstroke, and maximum deflection index from one peak to nadir, and then shortest RS complex. This all helps in localization of classifying the VT as epicardial VT. So this is one diagram which is very important to understand the things, because it divides heart from posterior and upper surface. It divides it into four quadrants, two upper quadrants and two lower quadrants. This is upper quadrant is right upper, left upper, right lower, and left lower quadrants. So this is right upper quadrant. This will we should remember all these things, all these VTs or VPCs which arise from right upper quadrant. Posterior RVOT, right coronary cusp, parahesian, and septal tricuspid valve. And this is left upper quadrant. This consists of anterior RVOT, RV and LVOT. We should remember that LV is left and anterior, and aorta is right and posterior structure. So this should be kept in mind while localizing VPCs or VT arising from RVOT and LVOT. So these are structures in left upper quadrant: anterior RVOT, left coronary cusp, LV summit, aortomitral continuity, superior mitral valve, left anterior vesicle, and anterior papillary muscle. So this anterior vesicle and papillary muscle comes in left upper quadrant, and posterior vesicle and posterior papillary muscle comes in left lower quadrant. And other than this, left lower quadrant is inferior mitral valve, left posterior vesicle, and left anterior papillary muscle as already described. and this is left right lower quadrant. Right lower quadrant is right ventricle. This is inferior tricuspid valve, crux, and moderator band. These all structures comes in right lower quadrant. So this figure, we will come to this again and again in localization of VT. When we have to first localize VT to one of these quadrants, and then final localization, differential diagnosis among the structures which are there in the respective quadrant. So this is the first step in localization of VPCs or VT. So first we should see that superior or inferior axis. Any focus which lies in upper part of the heart will have a vector downwards. So it will produce a inferior axis, and anything which is focus which is arising lower part of the ventricles will produce a superior axis. So we will look at the lead 2 and 3. If lead 2 and 3 are positive, it means there is focus is in the basal part of the heart. So basal area including both outflow tracts and superior part of aortic valves, and this mitral and tricuspid valve. This all will produce a superior axis in the VPCs or VTs. And if 2 3 is negative, it means it is focus is arising from the inferior part of the ventricles. So lead 2 and 3 have positive pole lower side, so it vector is going away from the positive pole, so it will be a negative complex in lead 2 and 3 when focus arises from the lower part of the ventricle. So first we classify it in whether it is upper quadrant or lower quadrant. So upper quadrant structures will produce inferior axis, lower quadrant VPCs will produce superior axis. So now second step is to distinguish between right and left of midline in upper quadrant as well as in lower quadrant. So when we try to distinguish right and left of midline, means right upper quadrant versus right left upper quadrant, we will look at the lead 1. So all the structures on right side, their vector will go towards left arm. So this lead 1 will be positive. Lead 1 will be positive in all these structures. This is RVOT, right coronary cusp, parahesian, and superior tricuspid wall. VT arising from these structures close to these structure will have lead 1 positive. And all structures on left upper quadrant, anterior RVOT, left coronary cusp, anterior aortomitral continuity, anterolateral mitral valve, LV summit, and these all structures will produce lead 1 will be negative in these. So by this superior first step is superior and inferior axis, second step is right versus left. For upper quadrant we see lead 1, and for lower quadrant, to distinguish that lower quadrant it is arising from left ventricle or right ventricle, we look at the bundle branch block. So if it is left bundle branch block, VPC is arising from right ventricle. If it is right bundle branch block, VPC is arising from left ventricle. All these structures of left ventricle. So RV structures, inferior tricuspid valve, moderator band, and cardiac crux, they will produce LVB morphology. So and LV structures like inferior mitral valve and posterior medial papillary muscle and left posterior vesicle, they all will produce right bundle branch type of pattern. So by these two steps, we come to one quadrant, or superior or inferior quadrant, and then right or left superior quadrant. Then when we finish this step 2, we can focus on one quadrant only. We will come to right upper or left upper or right lower or left lower, depending upon superior and inferior axis, and lead 1 morphology and bundle branch block pattern. So we come to localize towards to the one quadrant. Now we have to distinguish all these structures of one quadrant. They depend upon different ECG morphologies. We'll come to that. So this is superior quadrant, we see lead 1. For inferior quadrant, we see bundle branch block for left and right differentiation. Now step 3 comes to the refined localization. Refined localization of group of structures which are present there in the one quadrant, right upper, right lower, left lower. So these are the some of the basic things that as we move from anterior to posterior, this is the transverse section of the ventricle. V1 is anterior part of right. This V1 morphology. By this V1 morphology, we can assess whether it is anterior part of RVOT, posterior part of RVOT or right coronary cusp. Right coronary cusp and posterior RVOT are together, close together. So differentiation among this is difficult. So when it is anterior part of RVOT, it will be LVB type of pattern. And as we move from anterior to posterior, this R wave grows in V1. So when we reach the posterior part, that is mitral annulus, posterior part of the mitral annulus, this is posterior mitral annulus. This will be complete RBB morphology, and in between R wave will grow from anterior to posterior. This is right coronary cusp, left coronary cusp, and aortomitral continuity. There will be distinguished R wave in like this in diagram number 4 in V1 lead. So this diagram is to be kept in mind. So anterior RVOT, posterior RVOT, aortomitral continuity, and this posterior mitral annulus. So now among these quadrants, once we have localized to this right upper quadrant. So right upper quadrant consists of RVOT, right coronary cusp, parahesian, and superior tricuspid valve. So one now we want to differentiate among all these 3-4 structures of the right superior quadrant. So general rules are, as the origin of VPC move from free wall to septum and from anterior to posterior, there will be early transition. So in septum, there will be early transition. As we move from septum to free walls of right or left ventricle, there will be later transition. And similarly, as we move from anterior to posterior, there will be early transition. In posterior structures, there will be early transition. As we move anterior, there will be later transition. So we have localized to this right upper quadrant. Now we see the lead AVL. AVL will be negative in RVOT and right coronary cusp. In RVOT and right coronary cusp. If there is initial R wave in AV1, initial R wave deflection, then we can localize it to tricuspid free wall or tricuspid septum and parahesian. So if there is initial R, then we look at the transition. If it is early transition, it means it is a central structure, tricuspid valve near tricuspid valve septum or parahesian. If there is initial R and transition is beyond V4, it is tricuspid free wall. If negative AVL is totally negative, then we also look for the transition. It is early transition in right coronary cusp and later transition in posterior RVOT. Posterior RVOT will have later transition, and this right coronary cusp will have earlier transition. So this way, by transition, we can differentiate among these 4 types of VPCs. And AVL and AVR are located superiorly. So AVR and AVL will be mainly negative in this outflow tract VPCs. Most of the VPCs, 70%, arise from RVOT or LVOT, these outflow tract VTs. So AVL and AVR will be mainly negative in superior part of the heart VPCs. So we have distinguished, this way we can distinguish right upper quadrant VPCs. So now coming to the left upper quadrant, this consists of more structures as compared to right upper quadrant. This is anterior RVOT, left coronary cusp, pelvis summit, aortomitral continuity, superior mitral wall, left anterior fascicle, and interior papillary muscle. So now we see the transition. If it is transition is early, then it is left coronary cusp, LV summit, aortomitral continuity, top of mitral wall, anterior papillary muscle, or left anterior fascicle. So now among these all structures we can differentiate by specific features for each. Like left coronary cusp, VPC or VT will have NOS V1. LV summit is epicardial, so it will be pseudo delta wave. And left anterior fascicle is central structure. There is depolarization of conduction system, so it will be a narrow QRS complex and a small r or in V1. And papillary muscle will have wide QRS complex as compared to anterior fascicle, and there will be QR in V1. And top of mitral wall, this is central structure, so there will be R in V1, significant R wave in V1. So by this specific features for each VPC, we can differentiate left upper quadrant VPCs. So if among these, if transition is early, it is left coronary cusp. Left coronary cusp has early transition, and anterior RVOT has later transition. And LV summit also has earlier transition and pseudo delta wave. So these specific features we can distinguish between these structures. So now this is also important V3 transition. So if we see PVC transition and sinus rhythm transition, if transition in PVC is later than sinus rhythm transition, then it is 100% RVOT VPC. So this is very important feature which differentiate between RVOT and LVOT VPCs. If transition is later than sinus rhythm, transition in VPC is later than transition rhythm, sinus rhythm. So we see transition in sinus rhythm is in V1, V2, and transition in VPC is in V2, V3. So there is later transition, it means it is 100% RVOT. If transition of PVC is at or before sinus rhythm transition, then most of the time it is LVOT. We have to differentiate further in this. So we have to see the transition ratio, V2 transition ratio. V2 transition ratio in sinus rhythm complex and V2 transition ratio in and VPC complex. If transition ratio is more than 0.6, it is LVOT. If this transition ratio is less than 0.6, it is RVOT-VT. And if transition in PVC is later than sinus rhythm, then it is 100% RVOT. So by this algorithm is important to differentiate between RVOT and LVOT-VT. So uh, now this type of complexes we see in VPC. If VT has all positive concordance, all all QRS complexes looking upwards, it is basal location. VT has a basal location. If all QRS complexes are looking downwards, there is negative concordance, it means it is apical location. So if LVB later transition, it means it is close to apex. If RBB type pattern and later transition, it is close to base. So this is one more differentiating feature to differentiate between base and apex VTs. Now localization of LVOT. LVOT is a complex structure. Different types of VPCs and VTs are produced from left coronary cusp, right coronary cusp, and aortomitral continuity. So left coronary cusp, already we have seen that this will produce M or W in V1. There will be notching in V1, and there will be earlier transition in left coronary cusp. Right coronary cusp VT will have later transition. Transition will be later as compared to left coronary cusp, and there will be R and R small r in V1. And this aortomitral continuity is a central structure. So there are all positive complexes. In chest leads, there will be all positive complexes or Q and small q in V1. So this is aortomitral continuity VPCs. So by this, clue to LVOT is V1, V2, R by QRS duration is more than 0.5. So by all these, applying all these things, we can differentiate between coronary cusp, right coronary cusp versus left coronary cusp VPCs. So LV summit is a complex structure. This produces a this can produce epicardial VTs. So this structure is a triangle bounded by LAD, left anterior descending artery, left circumflex, and base is formed by great cardiac vein. So this VPCs or VT arising in this triangle is called LV summit VT. LV summit is most superior portion of epicardial LV. So this is the boundaries of this LV summit. So epicardial VT is suggested by slurring of initial QRS pseudo delta wave more than 34 millisecond. Intrinsic is deflection onset of QRS to peak of R wave more than 85 millisecond in V2, and RS complex duration, minimum RS complex duration more than 121 milliseconds, and characteristic V2 pattern. R wave less positive in V2 break pattern. R wave is less positive in V2 as compared to V2 and V1 and V3. So V1 will have R wave, V2 will suddenly have less R wave, and then V2 again have larger R wave. So this is called V2 pattern break, suggestive of epicardial VTs. So there are different, some structures are non-outflow tract VTs. So most of the VTs are from outflow tract, but there are important VTs which are around 20-30% of the VTs which arise from non-outflow tracts. These are left anterior fascicle or anterior papillary muscle. They come in left upper quadrant, and posterior fascicle and posterior papillary muscle. They come in left lower quadrant. So fascicles are, they will produce narrow QRS complex and RSR pattern in V1. This will be typical RBB with right axis deviation. RBB with right axis deviation is left anterior fascicle. RBB with left axis deviation will be left posterior fascicle. Similarly, for anterior papillary muscle, this fascicular VT will be narrower VT, papillary muscle VT will be broader as compared to fascicular VT. So it will also have right bundle branch pattern, QRS will be wider, and there will be late transition in papillary muscle VT as compared to fascicular VT. And lead 2 will be negative in anterior papillary muscle. It will be inferior axis in anterior papillary muscle VT, and there will be superior axis in posterior papillary muscle VT. So now coming to the lower quadrant, superior axis, it will produce superior axis, and this right ventricular structures will produce LVB, left ventricular structure will produce LVB. So in these structures we can differentiate by transition. If transition is earlier, structure is closer to the septum. So tricuspid valve, septum and crux will have earlier transition as compared to free wall. Free wall VT will have later transition. So by this we can differentiate this right lower quadrant. For left lower quadrant, we see R by S ratio in V6 for these structures. This is inferior mitral valve, papillary muscle, posterior papillary muscle, and posterior fascicle. These are structures in the left lower quadrant. So we see R by S ratio in V6. If R by S ratio is more than 1, it is inferior mitral valve. If R by ratio is less than 1, it can be papillary muscle, posterior papillary muscle, or left posterior fascicle. So left posterior fascicle will have narrower QRS, papillary muscle will have wide QRS. So by this we can differentiate all these VTs. So fascicular VT coming again, left posterior fascicle will have RBB with left superior axis, left anterior fascicle will have RBB with right axis, and fascicular VT will have earlier transition and narrow QRS complex. So papillary muscle VT and fascicular VT further differentiation is initial diffraction in fascicular VT is sharper. It is less sharp in papillary muscle. If there is initial Q wave in limb leads, it suggests fascicular VT. Pleomorphic activity is more common in papillary muscle as compared to fascicular VT. So this is about anterolateral papillary muscle and posteromedial papillary muscle. This will have RBB with right inferior axis. It will posterior papillary muscle will have RBB with left superior axis. So coming to the mid part, structures of the middle of the heart. So middle of the ventricles. This consists of tricuspid valve and mitral valve. This is tricuspid valve on right side and mitral valve on left side. So if lead 2 is positive, among differentiation among these mid right structures and mid left structures. In mid right structures, lead 2 will be positive and lead 3 will be negative. So it is called discordant between lead 2 and lead 3. Mid left structures will have positive lead 3 and mid right structures will have positive lead 2. So this is mid right structures are parahesian, moderator band and lateral tricuspid valve. And mid left structures are lateral mitral valve and anterior papillary muscle. These are mid left structures. So papillary muscle will have RS ratio in V6 less than 1 and lateral mitral valve RS ratio in V6 will be more than 1. And papillary muscle will have earlier transition and lateral mitral valve will have later transition. So mitral annulus VT, mitral annulus is a middle of the ventricle structure. So we will find all positive leads in chest leads. All chest leads will be positive. So all chest leads looking upwards, positive concordance suggests basal part. Focus is in the basal part of the heart. So mitral annulus PVC will have positive in all leads except in AVL and AVR and lead 1 because these are superior structures. They will have negative QRS complexes. All other QRS complexes will be positive in mitral annular PVCs. So after this, coming to the approach, overall approach to the VT, step 1 is, as we have already discussed, first decide about superior or inferior axis. Now, then step 2 is then decide about right or left of the midline. By these two steps, we come to one quadrant, left upper, right upper, or left lower, right lower. One of the quadrant will be decided by these 2 points. Now, for final localization, uh, we can refine further by precordial transition, QRS width, and QRS morphology. For right upper quadrant, look for AVL. For left lower quadrant, look for RYS in V6. And these two other quadrants, transition of QRS complexes in chest leads. So this is for fine refinement of the VTs. So for students, it is important to go by algorithm. So by algorithm, going by algorithm, you will reach very close to the focus of the VT. Even if you cannot pinpoint the final diagnosis, you will be very close to this, and then we can further confirm it by EP study and other diagnostic procedures. So step 1 is superior axis. So look in the this 2,3 AVF is negative, so it is superior axis. So it is 2,3 AVF is negative. So this will superior axis. Now step 2 is right or left of midline. So right or left of midline, look for the lead 1 and bundle branch block pattern. So it is left bundle branch block pattern. Left bundle branch block pattern with superior axis. It means it is right lower quadrant. So right lower quadrant is inferior tricuspid valve, crux, and moderator band. So you are left with these three things, and you can further find with fine diagnostic algorithm as we have discussed. You can come to the conclusion of these three focus. Step 3 is further refinement. So it is moderator band because there is later transition. Transition is in sorry. So this is transition in V5, V6 and QS in V1. This is QS in V1 and transition is later. So it is most likely moderator band VT arising from moderator band. So now coming to another example, this is 2,3 AVF is positive. So it is inferior axis. So it is inferior axis, sorry, it is inferior axis and it is right of midline because lead 1 is positive. Lead 1 positive means these structures will produce positive lead 1 and inferior structures. Now we have RVOT, right coronary cusp, parisian and superior tricuspid valve. Now there is R in AVL. Now we come to the AVL. There is R in AVL and there is early transition. R in AVL and early transition means it is close to midline. The structure is close to midline, so it will most likely parise in VPCs. So these are limitations of ECG localization, inability to correct for cardiac rotation. So these are applicable only in structurally normal heart, idiopathic VT for structurally normal heart. And lead positioning is to be accurate, and other deformities can cause confusion in diagnosis, chest deformities and aortic deformities, and LVH and other structural heart disease, and if there is any progressive conduction. So these are further learnings for this, and thank you very much.
Thanks, Dr. Isar. I think that was very masterly. And for the postgraduates, we have these talks put up on the IHRS website. So they obviously will need to go through it again. Just a comment before I hand over to Deepak. The cardiac activation is a three-dimensional activation. And still, Professor Isar says that you can study the ECG and pinpoint from where this VT is coming is because he's talking of idiopathic VTs, and they are usually focal VTs. He explained at the start that we are not talking of VTs in structural heart disease. So these are focal VTs, and therefore you can accurately localize them, or to a great extent localize to which region and from which cardiac structure they are coming. That's important for an electrophysiologist who's trying to pinpoint and reach that localization and ablate at that site. When he has the VT, this is the way he does it. When he does not have the VT, he uses the same principle by doing what is pace mapping. He can pace at the implicated site and see if he can produce a paced QRS, which is exactly identical to the VT QRS. And then this is accurate to the extent of being around 1 to 1.5 centimeter of the localized site. So it's pretty accurate, less than what is achieved by what is called as activation mapping. Anyway, I'll ask Deepak to have at least a 5-minute discussion before we let Professor Isar go. Deepak, are you there? Deepak Padmanabhan.
Yes, sir.
Yes, sir. Please.
As you mentioned, Dr. Ashish, I think we are okay. I think I agree with you. This is an absolutely exhaustive masterpiece that Professor Isar has given us here today morning. And it essentially encompasses the entire spectrum of where and how these extra beats come from. These are challenging arrhythmias, mainly when they are associated with symptoms or associated with heart failure. They are one of the rare causes where heart failure can be reversed. And so they assume great importance, especially when the ejection fraction is low. Now, to kind of summarize Dr. Isar's talk in just 2 sentences, and perhaps give a carry home message on the basis of his talk, is we need to know whether any PVC or VT originates from the outflow tract or not. The thumb rule to that is look at AVR, look at AVL. Anything that comes out from AVR, AVL, both negative, is the outflow tract. Anything that is not AVR, AVL negative comes from the non-outflow tract. And secondly, for fascicular VTs, which are the other common source, especially in the South Asian region, the presence of an upstroke of the QRS, which is very sharp, almost as much as a normal QRS, in the presence of either VA dissociation or the presence of the typical right bundle left axis morphology, should make us suspect the presence of fascicular VT. Why these two are important is because they do not lend themselves to installation of an ICD. They are actually arrhythmias that can be curative with ablation, and hence these assume special importance. The outflow tract PVCs are also very commonly nuisance PVCs, as you see on fitness grounds. When you get a lot of these beats in asymptomatic patients who will be sent to you for fitness, and we have to opine whether there is cardiac fitness. There should not be any challenge in providing cardiac fitness for these patients. And last but not the least, there is a score called the ABC VT score, which one should know or at least be able to apply using online calculators, especially for those patients who are asymptomatic for their PVCs and have a burden that seems significant. This actually lets us know the chances that these patients have for heart failure related hospitalizations over a mean of next 3.3 years. So this is my contribution to, as an add-on only to Dr. Isar's talk, which was a masterpiece in itself. I hope our audiences are able to take home a lot of messages from his talk. Thank you.
Right. I think Dr. Deepak has very well summed up that it's a talk that needs to be reviewed for everybody. Even if I would like to go again on the website and go through the things that he said. You must probably realize one thing, that he showed the heart where you were looking at it from the dorsal side, and you might be more used to when you see things from the ventral side. But I think keep that in mind as you go through that talk again on the IHRS website. Thank you, Professor Isar. I think that was truly masterly. That is the word that is apt for this presentation. We move on more so in the interest of the time. Discussion would always have been great here further also. But again, I think time is a constraint despite this being an informal meeting. So Gaurav, can you present your case that you had in the mind? Thanks, Dr. Isar. Gaurav.
Thank you. Thank you, sir. Thank you very much. Thank you, Dr. Ashish and Dr. Deepak.
Thanks.
Thank you, sir.
This talk will be chaired by Dr. Deep Chandraja.
Good morning, everybody. Sir, are my slides visible?
Yeah, you are audible also. Please.
Okay, thank you. So after this very detailed and prolific session from Dr. Isar sir, we'll just discuss how should we approach a patient of a ventricular tachycardia. So when a patient of ventricular tachycardia comes, we should be prepared for some background of the patient. We should ask in background, which is important for the management of the patient, which is whether the patient has CAD, prior myocardial infarction, or the patient had symptoms during exercise, fright or anger, or were the symptoms at rest, whether the patients had lightheadedness or syncope episodes in the past, or how the episodes were terminated. Can we get some history from the patient, whether he tried some vagal maneuvers, does he have some comorbidities like heart failure or thyrotoxicosis, or has a family history, similar family history, or of sudden death or heart disease. So most of the VTs come to the emergency with wide complex tachycardia. The dictum is, when the patient of wide complex tachycardia comes to emergency, he is ventricular tachycardia unless proved otherwise. The first thing we should see as a resident in emergency is the hemodynamics of the patient. What is the blood pressure of the patient? Is he conscious, oriented, or he is he has altered mentation? If he has unstable hemodynamics or hypoperfusion, there is no further workup is needed, and straight away electric cardioversion is indicated, and followed by ACLS protocol, CPR and revival. If the patient is stable, as we discussed, we should be prepared to jot down the points, whether the patient has heart disease, or whether the patient has coronary artery disease, most common, or whether the patient has any comorbidity like heart failure, thyrotoxicosis, how were the symptoms initiated or terminated according to the history. Once we are jot down the history, we get a fair idea of how the about the etiopathogenesis of the ventricular tachycardia. Then we should confirm if the patient is hemodynamically stable, and giving us time to analyze the ECG, we should see whether it is regular or grossly irregular. If it is grossly irregular, it is atrial fibrillation with a rapid rate, or if we have a prior ECG to compare with, we should compare it with the ventricular tachycardia axis. If it matches completely, then we should consider SVT with aberrancy. We'll discuss further about it, and we should consider adenosine. So how to differentiate between VT and SVT in the emergency? If the patient has wide complex tachycardia, first thing we should look for is the AV dissociation. If there is AV dissociation with R wave more than P wave in a wide complex tachycardia patient, it is VT. Then we should look for the concordance, whether the patient has what are the net R waves in the V1 to V6 precordial leads. If there is concordance, it is ventricular tachycardia. Then very important lead is AVR. If there is QR wave in AVR, or there is notching in the downslope of AVR, it is suggestive of ventricular tachycardia. Then we should come at V1 and V1. If there is V1R is dominant, and there is a not the upslope is slurred or the downslope is slurred with small r more than 40 milliseconds, it is ventricular tachycardia. If there is, in cases of patients with typical RBBB or LBB pattern with rapid initial upstroke or downstroke with R-R or RSR, the key is that the initial deflection of the V1 will be very rapid. Then it is a remote possibility we should consider of it being a supraventricular tachycardia. Once we are done with our diagnosis of ventricular tachycardia, we should quickly look for signs of what is the structural heart, whether the structural heart of whether the heart cardiac structure of the patient is normal or not. Then how we can look for telltale signs of ischemia in ECG, or we can get a prior history related to the ischemic heart disease or valvular heart disease, or we should look for a bedside echocardiogram to look for structural heart disease, or with the help of clinical examination, we have to first rule out whether the patient has structural heart disease, a dilated heart, or he has hypertrophic cardiomyopathy or heart failure or any prior MI, these things must be ruled out. If the patient doesn't have any structural heart disease and the cardiac function is normal, we should also particularly look at the RV also at this moment. And if the RV is dilated, then also, in the emergency we can be sure that he has structural heart disease. If the patient doesn't have structural heart disease, he will have probably idiopathic VT, as discussed, is either fascicular VT. Most common idiopathic VTs are outflow tract VTs or fascicular VTs. Fascicular VTs respond very well to verapamil. They are called as verapamil sensitive tachycardias, and outflow tract VTs respond very well to beta blockers. IV beta blockers. If they don't have, then we have to go for IV beta blockers or amidron or procainamide or lidocaine. Lidocaine in case of acute coronary syndrome is better. So coming to a case of this is a narrow complex tachycardia which was terminated by adenosine in the emergency. If we look at it very carefully, we can see that the AVR is positive, which has slurred upslope. So this is suggestive of VT unless proved otherwise. And once we revert it and the QRS axis changes, then also it proves that it is VT. So this is RBBB with 2-3 AVF down with this is suggestive of, this is the classical ECG of fascicular VT. So fascicular VT is defined by a triad of induction with atrial pacing, RBBB with left axis deviation and absence of structural heart disease, and has verapamil sensitivity. So it can be a left posterior fascicular VT or anterior fascicular VT or a septal VT, depending where it is exiting. So it has a mechanism of re-entry. As shown, it goes down to via the specialized via the accessory area of slow conduction and comes back by the posterior fascicle. That is the most common thing. Most commonly, it affects 15 to 40 years male. Most commonly occurs as rest, usually paroxysmal, and it can be incessant and lead to tachycardiomyopathy also. It is verapamil sensitive. Medical therapy is usually effective in long term, but if the patient has repeated episodes of tachycardia, he may need ventricular tachycardia ablation. So this is another ECG which can present similarly like right bundle and right bundle branch block and superior access. So we should look at this as a right bundle branch block, superior access. So this is not coming from the outflow tract. This is coming from somewhere in the. So this is coming from the RV LV septum. So similar ECG with outflow tract. If the patient has multiple ECGs with one presenting with outflow tract ECG and another ECG with a different morphology, then we should suspect a disease of the RV, which may be ARVC, if the patient has multiple morphology VTs from the outflow tract as well as from the apex of the RV. In that case, the various societies have given us the diagnostic criteria. Histological diagnostics are the So this is right bundle branch block with superior access. This is suggested from coming from the basal septum. If the tachycardia comes from the basal septum, we should suspect sarcoidosis in this case. So if we can consider if there are two clinical criteria for sarcoidosis are presence of AV blocks and heart failure in a young patient, which is presenting with VT with RBBB and superior access with eco-suggestive of thinning of the basal septum, RWMA, aneurysm, and wall thickening. This will be eco will suggest basal septal wall thickening, aneurysms, RWMA in coronary artery non-coronary artery distribution, increased myocardial wall thickness, LV chamber dilatation, decreased LV systolic and diastolic function. The disease sarcoidosis begins in the basal septum and progresses to the septum downwards and can involve both right and left in the long term. we can pick this up in echo with by thinning of the basal septum and dilatation of LV and RV in the later stage. FDG PET is indicates the inflammation of the heart with shows us the inflamed heart as shown in this figure, which is pre and post therapy. And cardiac MR will again show us the thinned out ventricular septum. The key point is the distribution of the disease through various modalities like echo and MR is diagnostic. In the background of LGE is diagnostic of sarcoidosis. So in the case of non-ischemic cardiomyopathy like this, the role of CMR and the imaging modalities is very good for our diagnosis. This is the MR, 3D LGE and FDG PET in the same image, fused in the same image, localizing the scar at the basal septum well for us. Myocardial biopsy has a low yield, but if we do the EP guided biopsy at the low voltage areas, then it shows us, then it has a higher yield and can show us the non-caseating granulomas. Management is immunosuppression. For the acute phase, steroids are indicated. For the long-term phase, steroid-sparing therapy like methotrexate, azathioprine, leflunomide, mycophenolate, mofetil, and cyclophosphamide are indicated. Guideline directed medical therapy is should be given for heart failure. Beta blockers should be used for caution, as this disease is near the conduction system, and a patient may have AV blocks. Antiarrhythmic therapy for VT, including amiodarone, can be given. Radio frequency ablation should be done with caution, as the disease is near the His bundle and the conduction system, which may lead to AV blocks, and recurrence is therefore common as it is progressive. This is another young male with recurrent syncope. As we can see, there is a clear tall R' wave in V1 followed by T wave inversion. This is a classical Brugada pattern. So this is characterized by coving ST segment elevation in V1 to V3. 2 millimeter elevation in 2 of the 3 leads is diagnostic. Complete or incomplete RBB pattern can be there. Pattern can be spontaneously or present or provoked with ajmaline, flecainide, or procainamide. Typical ECG pattern can be transient and may be detected in Holter monitoring. Brugada S1 SCN5A down regulation is the most common mutation. These are the three types. Now type 2 and type 3 are considered in the same group. Type 1 is the most pathophysiologically important for us. The key point is the ECG leads. If we are having a suspicion of in a young male with recurrent syncope in night in the presence of fever, then we should place the leads in one intercostal space above or one intercostal space below to bring out the Brugada pattern in the ECG. So Brugada pattern in the ECG along with documented VF or VT or a history of sudden cardiac death at less than 45 years of age, or family history of type 1 Brugada or inducible VT in ECG, EP, or unexplained syncope, nocturnal agonal respiration. So one of the following criteria in the presence of Brugada can help us diagnose Brugada syndrome. If the patient doesn't have Brugada, in the case of high risk suspicion in the presence of family history, we can give a drug challenge like flecainide, procainamide, ajmaline, or fliscainide in the following doses. And we should stop the drug challenge when the development of type 1 Brugada happens, that is result in the diagnosis, or there is ST elevation more than 2 mm with type 2 Brugada pattern ECG, development of ventricular premature beats or arrhythmia, or widening of QRS in more than 30% above baseline. Management is immediate treatment of fever whenever the patient gets it, or avoid alcohol, avoid drugs which escalate the Brugada pattern. ICD is recommended in patients those who have survived cardiac arrest, and in patients who have Brugada with unexplained syncope also. Quinidine may be useful in reducing VT events after ICD. So if the patient, another patient, young patient, if he goes to perform exercises, when his heart rate improves, he gets PVCs in patterns of bigeminy, and on peak of exercise, he faints. exercise-induced arrhythmia in a patient who has normal QT at rest should make us think of catecholaminergic polymorphic ventricular tachycardia. So the classical ventricular tachycardia at the peak of exercise can be bidirectional ventricular tachycardia or torsioid. The patient may degenerate, this tachycardia may degenerate into torsioids. The management is, as it is sympathetically driven catecholaminergic tachycardia, the key management is with beta blockers, which have membrane stabilizing properties, including propranolol, nadolol. The patient is asked to limit physical activity and he should not participate in competitive sports. Flecainide can be given to those who are not responsive to beta blockers. Coming to long QT syndrome, if such a similar patient with long QT at baseline develops sudden ventricular tachycardia at exercise commonly, is said to have long QT syndrome. The key point is that the reversible causes of long QT should be ruled out before labeling the patient as long QT syndrome, and the confirmatory test is with the genetic mutations. So long QT1 is because of the downregulation of KCNQ1 in the phase 3 of the action potential. Long QT2 is because of the downregulation of KCNH2 or HERG channel in the phase 2 of the action potential, and long QT3 is because of the upregulation of SCN5A in the phase 0 of the action potential. So most of the long QT1 syndrome are because of heavy exertion like swimming or emotion. Long QT2 are because of auditory triggers or in the postpartum period, and long QT3 usually develop this tachycardia at sleep and rest. These are the clinical markers of differentiating. So still long QT1, as we can see, is most commonly throws VT in exercise, whereas long QT2 in emotional stress and long QT3 in rest in this study. Clinical differentiation of on the basis of ECG is by this long QT1 is associated with broad-based T waves, which picks up from the QRS itself, whereas long QT2 has low amplitude notched biphasic T wave, whereas long QT3 has a long ST segment and followed by a T wave. So there are long QTS diagnostic criteria scores, which include the presence of corrected long QT syndrome, torsades, T wave alterance, low heart rate for age, presence of syncope, congenital deafness, or family members, family history or unexplained syncope. More than 3.5 points have high probability. So coming to the risk stratification, if a patient has long QT, didn't have VT till now, what is the how can we stratify him? If the patient has QTC more than 500, has LQT1 or 2, or a male LQT3 has a more than 50% risk of developing VT at less than 40 years of age, the main key treatment is beta blockers. The role of the beta blocker should be given to those patients who have long QT on ECG and had a syncope. Beta blockers are highly effective for those in LQT1 group, and beta blockers inhibit the VT in the exercise-driven ventricular tachycardia. But those who have any other trigger also should be given beta blockers, because the next VT can be because of exercise in those patients. If the patients are not responding to beta blockers, surgical left cardiac sympathetic denervation is the treatment of choice for these patients. ICD are indicated for secondary prevention of cardiac arrest, but these should be not be used in every patient, and surgical left cardiac sympathetic denervation is effective in almost all the patients. In LQT3, mexiletine, flecainide, and ranolazine can be helpful. A young female, this is a young female with syncope. Clearly, as we can see that AVR, AVL are negative, 2,3 AVF is positive. This is from the outflow tract. As we can see in the long lead V1 shown below, there is clearly we can look for AV dissociation. So this is ventricular tachycardia from outflow tract. So outflow tract VT is the most common type of idiopathic ventricular tachycardia. 70% originate from the RV side, 10% from the LV side. These tachycardias are sensitive to adenosine, beta blockers, and most of them can be managed medically, but they can rarely be incessant and lead to cardiomyopathy. Non-response to beta blockers is an indication for cardiac catheter ablation of this tachycardia. The differential diagnosis for RVOT VT is ARVD. So tachycardia associated with atriovascular fibers or Mahem fibers, atrioventricular reentrant tachycardia using right-sided accessory pathway, or VT occurring after repair of TOF. So how to differentiate between RVOT VT idiopathic versus ARVD? RVOT VT is predominant in females, whereas ARVC is slightly more prominent in males. ARVC in a later stage has epsilon waves and T wave abnormalities, and in echo there will be echo and MR, there will be RV dilatation, RVOT dilatation, and thinning of the RVOT, whereas there should be no structural abnormality in the idiopathic RVOT. There will be multiple morphologies of the RVOT VT in ARVC, whereas RVOT will have single monomorphic VT in all the recurrent episodes. BNP level will be elevated because of the RV involvement. So epsilon waves can be seen in V1 as labeled, and T wave inversion in precordial leads are the major criteria. And RV dilatation, as you can see in echo in the image on the top left, there is RVOT dilatation. The same can be confirmed with a more sensitive modality, cardiac MR, and the biopsy will show us the myocardium replaced with fibrofatty tissue. The management is beta blocker as the first line, and followed by sotalol and amedron in the as the main antiarrhythmic drugs. For a patient who has survived VT, ICD is must for secondary prevention of ventricular of cardiac arrest. ICD for primary prevention is considered where there is severe ventricular dysfunction, whether right ventricular or left ventricular dysfunction. So this is a patient who had presented with chest pain to the emergency. As we can see in the initial half of the ECG, there is R wave in AVR and RBBB and left axis deviation. So this is a ventricular tachycardia spontaneously converting to sinus rhythm in the next half of the ECG, with the peculiar finding is QS complex in the precordial leads with ST elevation, suggestive of acute anterior wall MI. So this patient had acute anterior wall MI and presented with a VT. The management in ACS for ventricular tachycardia is revascularization. We should consider beta blockers as tolerated. First, we should correct hemodynamics.
I think, Gaurav, we should sum up at some point so that we can have a little discussion with Deepchand.
Okay, sir. IV lignocaine and amedron are the good drugs. For chronic coronary syndrome, it is usually related to scar. And we should look at the ECG suggestive of feature suggestive of chronic coronary syndrome. Beta blockers is the first line of treatment again. And these are the trials. AVID and SIDS are primary for the, they showed the benefit of amedron and ICD. CAST1 and CAST2 showed us that flecainide and encainide increase mortality in cases of coronary artery disease. And in VANISH VTAC trial, we studied the recurrent VT can be reduced with the shocks can be reduced with the help of VT ablation. In the recent Pratita trial, ventricular tachycardia ablation after first appropriate shock was associated with reduced primary composite outcome with primary driven by fewer ICD shocks. In the recent revised BCIS2 trial, we studied in patients who have severe LV dysfunction and extensive CAD. The CABG, we know that improves outcome in long term, whereas PCI was not shown to do so. And VT ablation in those patients of this subgroup had monomorphic VT led to similar outcomes in respective of prior coronary assessment. it had a small sample size, and post-hoc, it was a post-hoc analysis. Thank you.
Very nice. Very, very nice, Dr. Gaurav. That was a very exhaustive discussion on how we approach ventricular tachycardia. Are you able to hear me?
Yes, we are. Yes, we are. Please go ahead. It would be nice that you can sum up this.
Yes, sir. So we for the students who are watching this and attending the seminar, so we started off learning to localize a ventricular tachycardia, right ventricle, left ventricle, and where in the outflow tract, or is it from the mid part, or is it from the apical part of ventricles. So we learned to localize. And in this presentation, Dr. Gaurav has very widely and elaborately talked about how do you approach a case of ventricular tachycardia. A few points here. The approach to a ventricular tachycardia starts with history, and Dr. Gaurav exactly mentioned how history is important. The more you really get, even at this point of time, with so much of advanced investigations available, most of the clues are got to the history. History is where we get a lot of answers to the diagnosis. And when you look at the ECGs, be it a wide or a narrow QRS tachycardia, the best clues of whether this is a VT or not a VT, the best clue is from a previous ECG of the patient. Previous ECGs of the patient and the ECG post-cardioversion. After cardioversion, what is the ECG? If you have a right bundle branch block in the sinus rhythm, and then probably the so-called white complex tachycardia that we were dealing with was probably not ventricular tachycardia. So this is the best clue that we can get from a ventricular tachycardia ECGs, if at all we are thinking. And again, as far as the hemodynamics goes, yes, very important, blood pressure. When we say hemodynamics, it's not only blood pressure, it is also the heart failure symptoms. If one of these BP is low heart failure symptoms, we should not wait to cardiovert the patient. So cardiovert the patient, there's no debate on whether it is VT or not VT. Forget about what is there in the ECG. Patient is hemodynamically unstable and we need to cardiovert. That's it. So after cardioversion, you can have all the discussions whether it is VT or not VT and all that. And if the patient is hemodynamically stable, then again, no tension because the patient is already hemodynamically stable, so that you have considerable time then to understand whether it is a sustained, non-sustained, monomorphic, or a pleomorphic or a polymorphic ventricular tachycardia, whereas polymorphic ventricular tachycardias are rarely hemodynamically stable. They are always, for all practical purposes, polymorphic VTs are unstable VTs. And then again, a few points. Narrow QRS tachycardia can also be ventricular tachycardia. Picking up VA dissociation in ECGs is a very critical step in diagnosing VT versus no VT. So this comes with practice, comes with looking at a lot of ECGs time and again, and spending time on the ECG, trying to understand every stroke in that ECG, trying to question whether what could have caused this problem, and discussing with your peers and discussing with your seniors, discussing with your colleagues. And over time, you will definitely master the art of picking up VA dissociation. And once you know to pick up VA dissociation, then you have the diagnosis spot on. It has to be ventricular tachycardia. Narrow QRS tachycardia can always be a ventricular tachycardia. Can also be a ventricular tachycardia. That is again something that we need to remember, especially vesicular VTs. And anatomically, as Professor Hisser was pointing out, anterior right ventricle outflow tract is in fact anatomically is to the left of the midline. LBB morphology VT can be from the left ventricle. RBB morphology VT can from the right ventricle. It all depends on where the exit of the VT is. Localization of the VT is more applicable to structurally normal heart. In the presence of a scar, that could be deviations from the algorithms which we can understand. And management, as we had said, management of VT all goes by the hemodynamics. Beta blockers, amiodarone, lidocaine, these are the common drugs that we use. And of course, we have upcoming talks on how to manage VT storms and henceforth. But then there was a slide put up by Dr. Gaurav highlighting IV procainamide. This is something I wanted to ask. I have never used this, Dr. Ashish and Deepak. I wanted to know from you, but I have heard people talking about IV procainamide. Is that available commonly? And when do you think you use it, IV procainamide?
So, Deep, to answer that, it was IV procainamide called Pronestil was available in Europe, at least Deepak can say about US. And it was used in patients who have hemodynamically stable VT in a post-infarct scenario. And I mean, it's a old remote myocardial infarction and VT. In that setting, it was used to terminate an acute VT because it acts faster than amiodarone acts. The only negative side to it is more negative inotropic as compared to amiodarone. So one has to bother about whether there'll be a drop in blood pressure after you give Pronestil, and maybe you cannot at all use it when there is a borderline blood pressure. But it would terminate a VT faster than what amiodarone used to do. So there was a role for Pronestil or procainamide, but we have, I think, some 25 years back, maybe had it for a short while, but since then we never had it here. Yes, Deepak. Okay.
Thank you, sir. I agree
Yeah,
with
sure.
you. I think it was very useful, but the negative inotropic effects make it always a challenge. There's always a chance that if you don't convert, you're actually reducing the blood pressure on it. So we didn't use too much of it, have heard of it. It's a good drug in certain situations, especially non-VT related, VT-like situations. But for the most part, I think if in doubt, just revert the rhythm. That remains the thing of choice. For any wide complex tachycardia, if in doubt, revert the rhythm, then figure out the intellectualities of the whole thing.
Sure.
Yeah,
Just
thank
Deepak,
you.
before you close, maybe a passing comment on why there was a need to differentiate between that ARVC related VT and idiopathic RVOT VT. Then we can move on to the next one. Can you make a comment on that, Deep? Deep, could you make a comment on why is there overlap between an idiopathic RVOT VT and an ARVC related protract VT?
Yes, this RVOT-VT, in fact, we are also learning that most of the RVOT-VTs that, especially the sustained monomorphic VTs that we ablate, over time seem to develop features of right ventricular cardiomyopathy. At the initial stages, we think it is idiopathic because we go by the echocardiogram mostly, and badly that, we subject them to cardiac MRs, all the patients. Rarely all the patients have things. But most of the thing, if the echo goes normal, then we think it is an idiopathic RVOT-VT. But irrespective, for all these students, if you have an idiopathic RVOT morphology ventricular or RVOT morphology ventricular tachycardia, please have a look at the sinus rhythm ECG. And if you have these epsilon waves or fractionated QRS or an incomplete right bundle branch block in V1, then do have a look at the echocardiogram again and do subject the patient to a cardiac MR test. Probably we are looking in terms of right ventricular cardiomyopathy. These are the patients who are going to recur. Practical reasons why we need to pick it up, because they are going to recur or there are high chances of recurrence, and they might need idiopathic RVOT. We don't need to keep them on any medications for start of ablation. And if you are suspecting ARVC, you need to keep them on preferably oral antiarrhythmic drugs like beta blockers for a long period of time. So it is important to have a look at the sinus rhythm QRS morphology, especially in V1.
Right. Sure. So I think once again, in the interest of time, let's move on to Dr. Ankit Jain, who has to tell us about what we do in the lab with these VTs. Ankit, can you start your presentation?
Yes, sir. Am I audible, sir?
Yes, your slides are yet to come. Yeah, they're there. Yeah, please go on.
So, good afternoon, everyone. The task assigned to me is to talk about the basics of mapping and ablation of VTs in structural heart diseases. So, so I will be starting with mechanisms of VT and what is the structure of the VT circuit that we need to map. Then the various mapping techniques like substrate mapping, activation mapping, entrainment mapping, pace mapping, and then we conclude. Okay. So focal pattern VT. So focal is a pattern when we have a point source of origin, and then there's a centrifugal activation of the activity into the cardiac chamber, that is the origin of the tachycardia. The focal pattern we see when we map these type of VT by electroanatomical system, the mechanism underlying this focal activity is most commonly a triggered activity that is delayed after depolarization or sometimes enhanced automaticity in disease tissue. It is common in patients without any structural heart disease, and the paroxysms of this VT can be brought about by the catecholamines because it is a calcium-dependent VT. So we can induce it in cath lab by fast ventricular pacing also. And it is important to notice that up to 10 to 15% patient with structural heart disease can also have focal VT associated with re-entrant VT they have. And it is important to recognize them because because there is a failure to terminate with these VT with anti-tachycardia pacing and PC cardioversion by the implanted devices. And re-entrant VT is the commonest VT in patients who have myocardial fibrosis and structural heart disease. And the circuit of this ventricular tachycardia is commonly located where at the myocardial fibrosis location in that particular patient. So that fibrosis can be at the epicardium, can be at subendocardial or endocardial, can be entirely intramural, or can be transmural depending on the etiology of the disease that we are dealing with. So for example, in coronary artery disease, most of the scar is subendocardial. It is commonly epicardial and intramural in patients with non-ischemic cardiomyopathy. It starts with the epicardium in patients with ARVC. So early VTs in ARVC can generally arises from the epicardium because from there the disease started and the scar formation started. Re-entry circuit of the VT is commonly located at the border zone of the fibrosis or scar. So at the border of the dense scar and the normal myocardium, where we can find some surviving muscle bundles that are injured but not completely damaged, and they present inside the scar and they serve as the protected isthmus for that VT. So the identifying of these surviving myocardium inside the scar by various mapping techniques is the core principle of the VT ablation. So these surviving muscle bundles are located at the low voltage area and they have a electrical property altered because of the disease. So they conduct slowly and they have the property of conduction blocking in the one direction and conduction allowing in the next direction. So they can serve as a VT isthmus. I will explain this in the later slides. So this is a picture from a publication that shows a subendocardial scar in patient with ischemic cardiomyopathy. We can see dense scar in the subendocardial and the epicardial region is relatively healthy. And there is a muscle bundle present inside the scar that has a slow conduction delineated by the break lines, and that served as the VT isthmus. It is boundaried by the two non-excitable areas, and the conduction can propagate from this VT isthmus and can exit into the healthy myocardium, from where we can see the onset of the QRS when it exit in the healthy myocardium. But the activity of this corridor is relatively silent in the ECG, and it happened during the electrical diastole between the onset of the QRS and to the next QRS. So the purpose of the mapping is to find out where these channels are located, whether it is in sinus rhythm or in the ventricular tachycardia by various mapping techniques to increases the chances of the ablation. So one word about the structure of the VT isthmus. Although VT isthmuses are generally a three-dimensional structure, but I have to simplify it, it is shown as a two-dimensional structure here. So it is formed by a surviving muscle bundle that is a thin sheet of myocardium from which the conduction occur, and it is boundaried on each sides by the areas of conduction block to prevent the short circuiting of the circuit and abolition of the tachycardia. These lateral boundaries of conduction block is formed by that can be a fixed boundaries or a functional boundaries. Functional means that these boundaries are present during tachycardia or during some paced rhythm or at higher rates, but not present during sinus rhythm where we are mapping these, looking for these boundaries. So it can be a functional boundaries or anatomically fixed boundaries that are present whether we are in VT or in sinus rhythm. Generally, a mixture of all of these functional and anatomical boundaries form the circuit. So, and the another property of the circuit is it has slow conduction at some point to propagate the re-entry. So when the conduction, when the propagation enter the circuit and exit, and then it propagate to the isthmus and then exit at the healthier myocardium. The slow conduction in the circuit is found by because of the various mechanism like gap junctions redistribution, anisotropic conduction. That means the conduction is faster generally in the longitudinal axis of the fiber and slower at the transverse direction or perpendicular to the fiber. That property accentuated in reduced myocardium or source sink mismatch. When we have a smaller myocardial cell that is trying to activate a larger group of myocardial cells, then there is a high chances of conduction block, because the amount of current that is activating the larger myocardium, the safety factor of the conduction decreases and conduction can block at these locations. So this is a very important property of the cells that make up the isthmus to have the property of conduction block, because this is essential for VT initiation. So this is unidirectional conduction block is showing when we are pacing outside the circuit, the conduction is propagating through both the direction. But when there's a short coupling interval, programmed extra stimulation or a VPC with short coupling interval, it can block on one direction and then it propagate to the other direction, and then this site have been recovered by its block, and that propagate the re-entry. That's why we need a critically timed BPC or programmed extra stimulation to initiate the re-entry and the VT. So this property can be used for our advantage when we are mapping the substrate in sinus rhythm. We can look for the fibers that have the property of delayed of conduction block or decremental conduction. So pre-procedure planning, so we want to know before going into the lab, where is the location of the scar. But cardiac MRI can show us the location of the scar, whether it's intramural, subepicardial, epicardial, or subendocardial. By looking at the late gadolinium enhancement, it can give an idea about the etiology of the particular disease. The CT scan can also help, has a higher spatial resolution, and can show the wall thicknesses. As I have explained, that the wall thickness is generally reduced at the site of the VT isthmus. So the CT scan can also this thing. So beforehand, where the channels are located, they can be integrated and correlated with the substrate mapping in the electroanatomical mapping system, and then we can have a anatomy beforehand also. So, and also the analysis of the ECG is very important because it suggests the exit site. Although the diastolic activity is silent in the ECG, but it can suggest the exit site and can tell us where our mapping should be focused. And if we have no ECG available during the VT, and we can use the devices EGM analysis if the patient already had a device to the and compare those EGM with the VT induced inside the lab, and then we can know which VT is the clinical VT. We generally tend to continue antiarrhythmic drugs if the patient is having VT on them, because they can slow down the VT and make our VT mappable in the lab if we want to do the activation mapping. We should consider for the hemodynamic support, and we can beforehand assess the risk of the patient going into the hemodynamic collapse by some there are scores available for that, and we can use IABP or Impala if available. We should consider the patient will need post-procedure anticoagulation if we are extensively ablating inside the left ventricle, and so should be prepared for that. So substrate mapping means that we want to know where the location of the scar and the slow conducting myocardium are present. Where they are present, we can map in the substrate in sinus rhythm, pace rhythm, or extra stimulus pacing with various advantages of each of them, because some electrograms are visible in sinus rhythm or pace rhythm or extra stimulus rhythm, but they are completely normal in sinus rhythm. So it is the most useful mapping techniques in patients where we cannot map the VT in poorly tolerated or non-sustained VT. To identify the low voltage area where we need to go and map, and it identify the EGM markers of slow conduction. So we generally take the voltage cutoff of 1.5 millivolt. More than 1.5 millivolt is taken as normal for bipolar voltage map. 1.5 to 0.5 is taken as the border zone. Less than 0.5 is taken as the scar. So this is valid for I think these cutoffs were derived from when we were mapping with the 3.5 millimeter tip ablation catheter, but with the availability of the smaller closely interspaced catheter, these cutoff might need to change, and the voltage may be different when we map with the micro catheters. So this is an example. I've taken this picture from a publication. So this on the left-hand side, when we map from the larger tip catheter, we see a dense scar in the anterior wall of the left ventricle. But when we map with the micro electrodes, we can see surviving bundles inside these dense scar, and where they are might hovering the VT circuit. So these micro electrodes better identify the surviving bundles in smaller viable area inside the scar. So what are the markers of the surviving bundles during electrogram analysis? So we have various markers for slow conduction, like late potentials. Late potentials is defined as when there's just a local signal after the far field ventricular activity, and there's a isoelectric gap between the far field activity and that point signals. And so these are the products of the slow conduction or markers of the slow conduction. Here we are seeing a wavefront entering a slow conductant area that is denoted as the number 2. So the 2 number is a slow conducting area. So we can get a fractionated signal with multiple peaks here. And then after that signal, as the conduction is already slowed by the slow conducting area, and the wavefront after that propagated from that area will show a late potential. So late potentials may or may not be specific for that slow conducting area, and there are other mechanisms also, like wavefront collision or different pacing wavefront orientation that can bring about the late potentials. But these all are markers of the slow conduction and have a higher sensitivity but very low specificity for the VT isthmus localization, and we can do it in sinus rhythm. That is this advantage. So the late potentials, lava potential, and fractionated potentials are markers or result of slow conduction. They're dependent on rate of the rhythm we are mapping, type of rhythm, whether it is a paced rhythm or from which side this we are pacing, whether from the left ventricle or right ventricle. We have to map multiple times with multiple pacing sites if we are not getting them in sinus rhythm. So, but they are not specific for slow conduction or potential VT circuit, because in a patient with scar, we can have multiple sites with these low potentials or lava potentials. So specificity can be improved by some techniques. If we see that for VT induction, we need a unidirectional block. So if we can pace at the site, some site far away from that late or lava potential, and we can show that potential decrement with the pacing, then we can be more specific that site will lead to a VT circuit formation. For example, in this case, there was nothing visible on the S1 pacing or mapping or sinus mapping, but when we give extra stimulus, these signals separate, and and this is defined as decrementally evoked potential, and they are more specific for VT. So we can show that from this slide that some signals can be decrement, and that can be very specific for VT. This is another case where we have seen a lava potential at the border of the scar. The scar is shown from on the left side, the substrate map, and there's a red portion is a scar, and then there's a border zone, and the purple is the normal voltage. So at the border zone, we found a lava potential, and then we induced the VT in the lab, and we found that this is the site where we found the mid diastolic potentials, and the entire VT circuit was located at that site. So we in the sinus rhythm also, if we can locate these signals, and we need not to induce the VT, and in the VT they generally form the potential, the diastolic corridor. Activation mapping require that the VT is stable, it is not changing in the QRS morphology, cycle length is stable, and patient is hemodynamically stable. If we can do that, we can found that the mid diastolic and diastolic activity at the VT isthmus site, and then we can confirm whether we are actually at the circuit by entrainment, because we can have diastolic signals even if we are in the remote bystander area of fibrosis. We can have diastolic signals, but they are not related to VT. But if by entrainment we can prove that actually we are inside the VT circuit, and we can bring out the ablation. So in this particular case, we have mapped the slow conducting area in sinus rhythm at this particular size of parahygian area, and then we induce the VT by keeping our catheter already there, and we see the diastolic potentials and entire VT circuit located there. So it is good, but require a lot of things. So entrainment, a word about entrainment. Just the entrainment is overdriving the tachycardia from the at the faster rate than the tachycardia, and observing the response after we cease pacing. So the prerequisite is tachycardia should be stable, not changing cycle length, should be stable before and after the pacing. So there are criteria that prove that we have entrained the tachycardia. When we entrain the tachycardia outside the VT circuit, we can see the constant fusion. That means that the morphology of the pacing, and we see a mixed morphology of the pacing and the tachycardia. And there should be progressive fusion. That means if we increases the pacing rate, the morphology changes, and then and looks like more like pacing at the faster rates. And then there are other thing that if the conduction block and termination of the tachycardia with change in the activation sequence, that can also prove entrainment. So if we are exactly at the VT circuit, we will not see fusion. We will see exactly the same morphology. So this is known as concealed fusion. And if the electrogram to the QRS duration is equal to the stimulation to the QRS duration, we are at the critical stimulus of the circuit, and ablation here generally transect the tachycardia. So what is progressive fusion? If I can explain this. So in this particular case taken from a publication, this is we are pacing outside the circuit, and there are two wavefront. We are entering the circuit and then accelerating the tachycardia cycle length, and there is an antidromic wavefront that is already activating the part of the ventricle. So there is a fusion beats present before the at the pacing side. That is a mix of tachycardia beats and the pure pacing beat. And when we accelerate the pacing rate, the collision point between the orthodromic and antidromic wavefront is changed, and the pacing and the morphology changed. So this suggests that there's a progressive fusion, and this tachycardia is actually a re-entrant tachycardia. When we are exactly at the mid diastolic isthmus, then the most important thing to look for is that our stimulation to QRS duration and the EGM to QRS is same, and depending on the timings, we can know where we are at jet or the mid isthmus or at the entrance site. One word about pace mapping. If we cannot induce tachycardia, generally pace mapping is not very specific or sensitive for structural VT, but we can get an idea. If we pace at the exit site of the tachycardia, we will see the same morphology. But but there will be a stimulation to QRS. Stimulation to the onset of the QRS into the pace beat will be very short. But if we move toward the VT circuit, our stim to QRS will increase, and that suggests that we are at the slow conducting zone with the exit that is far away from that slow conducting zone. And also we can see multiple morphology exiting from that site, because we know that VT isthmus can have a multiple exit sites, so some morphology changes. If there's an abrupt change in morphology, now we are exiting from the entrance site, so we can we can find out that actually we are in the VT circuit. So changing in the morphology, just moving the catheter a little bit, or long stem to QRS with multiple morphology can suggest that we are actually at the VT isthmus. So now we have mapped everything. So how to ablate? So if we have done the activation mapping and identified the isthmus, nothing like that, just transect the isthmus, and then our tachycardia will be gone. But also these patients can harbor circuits in other areas also. So it's good to do substrate bit ablation on the other areas, like lava elimination, local late potentials annihilation, or degradation zone elimination, scar dechanneling, or scar homogenization. All these strategies are focused on ablation of every possible lava potential or late potential that is present. But it is easier said than done, because the lavas and late potentials are their mapping is different. We have to map in multiple rhythms to actually find out if we have got them all or not. So alternative to ablation techniques, we have because if there are deeper circuit or deeper circuits, our needs, and we need to a larger lesion formation, we can use multiple techniques. For deeper lesions with the RFA, we can use half now muscle lines or impedance modulation by multiple patches, or bipolar ablation or needle ablation. There are some alternative to RFAs also coming up, like pulse field ablation, cryoablation, chemical ablations by alcohol, radio ablation, or surgical ablation inside the operating theater if we cannot reach the substrate. So to conclude, VT ablation improves clinical outcomes. Most importantly, reduce the shocks and it decreases the morbidity. And now there is some data that has come that shows that earlier done is better. Their accurate pre-procedural evaluation increases success and avoid complications. All the mapping techniques are complementary and should be used that way. And maximum mapping and minimum ablation should be the goal. Thank you very much for listening.
Thanks, Ankit. I think you have really laid the way we do ablations in the cath lab. Deepak, you probably will have to sum up as to which patients you bring in for ablation. Say a line about each of these techniques: activation, pace, entrainment, substrate, and then why our success rates should not be expected to be like the SVT, the success rates like an SVT ablation success. So in short, just sum this whole ablation exercise in a way that is that can help a general cardiologist.
Thank you, sir. Excellent talk, Ankit. Wish we had more time to listen and learn from you. So ablation remains a double-edged sword in our country. Ablation cannot substitute implantation of an implantable cardiac defibrillator device. But given the fact that finances are always stretched in our country, for those who can't afford an ICD at the first episode of monomorphic VT, it is something that can be used. Assuming a perfect world, ablation is only done in patients who have recurrent monomorphic VT, and there has been no study to prove that there is mortality benefit. But the benefits have been proven to be in place for recurrent hospital admissions, decreasing recurrent ICD discharges. This is the Western world data. In an Indian scenario, it is still unclear what happens when you are ablating a VT without an ICD, number one. And number two, whether the first episode of monomorphic VT in an underlying substrate of scar is to be ablated or conserved medically. To go on from there to all the various techniques that Ankit so eloquently described, the key remains that if you have ventricular tachycardia, which is seen clinically, and you have a 12-lead ECG of it, going after the tachycardia in a setup where there is adequate post-procedure care is the option of choice. If, however, the tachycardia cannot be induced, the post-procedure care is likely to be challenging, or if the patient is in ventricular tachycardia storm, we will basically ablate the substrate using one of the various techniques, understanding the limitations of signal processing in those, and then attempt to induce an arrhythmia to see if the arrhythmia is further inducible. Non-inducibility of an arrhythmia at the end of the case remains the goal of these procedures. Thank you.
Thanks. I think that was well summarized. And once again, I must emphasize on all of you are a part of this and your colleagues who are not a part of this, that do visit the IHRS website and go through these talks at leisure, one by one, so that you understand what the EP does in the lab and what is the relevance of each of these therapeutics, how much success, when to use which. So once again, the time that we are always cramped with, I'll request Dr. Gupta Anunay to describe how he manages VT storm. I think this is very relevant to a cardiologist to know how differently a EP person thinks when he is faced with the VT storm, and why these patients should be handled in consultation with the EP specialist. Anunay. Your slides are on, Anunay, but we can't hear you yet. Are you on mute?
Yeah. Are you able to hear me, sir?
Yeah, now good. Please go.
So a warm good afternoon to everyone. And my job will be in the next 10 to 15 minutes to make you understand about VT storm and how you should manage the VT storm in consultance with electrophysiologist and your critical care specialist friends. So the outline of this short talk will be a clinical case in the beginning, and in the end, I will discuss how we manage that case, how we define VT storm, what are the triggers of VT storm, and how we should take care of those triggers. What is the acute management of VT storm, which will be managing the ICDs and other things, and followed by the medical drug therapy, sedation. Then what is the role of VT ablation in VT storm in the current era? Then few words about stellate ganglion blockade, which can be done easily by anyone, even bedside, without need of fluoroscopy or even an echo. And then radio ablation, which is an evolving field in last 5 years in VT ablation, and followed by the concluding this seminar. So we all know that VT is defined as a cardiac arrhythmia when we have 3 or more than 3 complexes which are originating in the ventricles, and the rate has to be rate more than at least 100 beats per minute. And when it comes to defining VT storm in a patient who doesn't have an ICD, so it is defined as occurrence of 3 or more hemodynamically stable VT arrhythmias within 24 hours. Sorry, I think, sir, I missed my, yeah, case will come later on, sorry. So the VT and a patient without an ICD, the VT storm will be defined as 3 or more hemodynamically stable VT occurring within 24 hours. Or when you give DC shock or amiodarone, it occurs soon after that. Or sustained, uneven non-sustained VT when the ventricular ectopic beats are more than half of the sinus beat in the 24-hour monitoring. Coming to this clinical case, this was referred to our hospital in VT storm. Here, as you can see here, you have an incomplete RBB in V1 with a no transition happening up to the V6, and superior axis with 2, 3 and ABF positive, suggesting arising from RB free wall or septum. And he was given amiodarone, beta blockers, adenosine, everything. The VT doesn't terminate, and then he was referred to our hospital for further management. They have done the echo of this patient before transferring to us, and it showed a large ostium secundum ASD, which was not diagnosed before this case. So he was a 24-year-old male coming to an hospital with this tachycardia. On echo found to have ostium secundum ASD, and this VT couldn't be terminated with amiodarone, lignocaine bolus, and DC shock, and then was referred to our hospital. Now come when the patient is having an ICD, how you define VT storm in those patients. It will be defined as 3 or more appropriate therapies of VT. Very important. There has to be an appropriate therapy, not inappropriate, which will include both either a shock and anti-tachycardia pacing. Means a patient comes to your OPD and it says that he has 3 episodes. You get the device interrogated. You see that he has received ATP 3 times in last 24 hours. So it means he's in VT storm and it's an emergency. You should admit that patient. However, the problem with this definition is that, for example, the VT is happening at a slower rate, like it is in the range of 120 to 130 beats per minute. So it's below than the program detection rate of the ICD. And if the VT doesn't terminate with appropriate ICD therapy and the patient doesn't know that VT happened. So this is the problem with this definition, that a slower VT and a patient doesn't know that VT has happened will be missed. Incidence of VT storm will vary. It depends whether it's for primary prevention, for a secondary prevention, how you program the device. It's a aggressive or a less aggressive programming. Then it will usually happen in patient with structural heart disease, like they have ischemic cardiomyopathy or non-ischemic cardiomyopathy. However, with channelopathies patient also present VT storm, they don't have any structural heart disease. So the risk was 2.3% per year in the famous MEDIT2 trial, in which the ICD was implanted for the primary prevention. And so if it is for secondary prevention, the risk will increase more. So the basic mechanism is there has to be a substrate for that. It can be either channelopathy due to sodium channel or calcium channel or potassium channel mutation. There has to be a myocardial scar. It can be an endoscar or an episcar in non-ischemic cardiomyopathy. Then there has to be some trigger. In the background of autonomic dysregulation, means increased sympathetic and less parasympathetic, it leads to ventricular arrhythmias, and that physical stressor continues and finally leads to storm. Triggers can be either reversible or non-reversible. Reversible, we all know we should look for electrolyte imbalances, any features, ECG features, symptoms suggesting of ischemia, patient has worsening of heart failure due to any reason, associated sepsis, patient has cardiac sarcoid, is in active inflammatory phase, or it can be non-reversible, like you can do nothing for the scar. Patient has ARVD, you have to treat the VT, not ARVD. Similarly, patient has channelopathy, you have to treat the VT accordingly. So VT storm is a deadly vicious cycle. So when it starts, it leads to low cardiac output, low blood pressure, sympathetic activation, and norepinephrine release. And this cycle continues until you break it. To diagnose it, you should try to have a sinus ECG so that you can compare to the VT ECG and rule out these other causes such as SVT with aberrancy, SVT with pre-existing bundle branch block, or any antidomic WP tachycardia, or any drug toxicity. So first you have to prove that it is a true VT and you are not looking in any other causes of wide complex tachycardia. So the basic management of this VT storm will be like, you, if possible, do a PA pressure monitoring, interrogate your device, look for appropriate versus inappropriate shock, do a quick echo, look for the LV function. If you can estimate, look for the filling pressures. If history suggests, do an angiography. Otherwise, no need for an angiography in patient with monomorphic VT storm. Do an X-ray, look for cardiomegaly and congestion, look for the vitals. Do a 12 lead ECG I discussed, prove that it is a true VT, not a aberrant VT, not an aberrant SVT basically. Look for the symptoms and triggerers and do the blood test. So the basic disease targeted therapy will depend on the triggers. For like a patient with ischemic cardiomyopathy comes to you, look for any worsening ischemia, do an angiography if indicated, take for ablation. Non-ischemic, you can't do anything, just do an hemodynamic support, do for an ablation. Patient with ARVD, sympathetic tone is high, treat it and target ablation. Same thing for myocarditis. These patient, young kids come to you in hospital with VT storm. The trigger is not inflammation. So you can try immunosuppressive therapy, which may be or may not be beneficial, and look and provide them hemodynamic support. When it comes to patient with no structural heart disease, such as Gaurav discussed, long QT syndrome, CPVT, Brugada syndrome, then you have to treat it accordingly. Said, for example, in Brugada syndrome, you have to increase the heart rate of the patient by using isoproterenol or quinidine if it is available. Similarly, if patient has outflow tract VT and VT storm, give beta blockers and verapamil. One of the most important factor of VT storm in patient with ICD is that you have to manage that ICD properly. So your role should be that you should avoid and minimize ineffective and inappropriate shock. So reprogram the ICD. Like, it should not stop giving shocks through the device, or you don't have a programmer nearby. Just use a magnet over ICD. What will it do? It will suspend the VA detection and therapies. However, it will continue the pace. So if maybe patient is getting inappropriate shock due to SVT with aberrancy or due to any lead fracture or any other thing, it will suspend giving the shock to the patient while it maintains the pacing function. And if programmer is available, you look for that VT is happening at a slow rate or faster rate, and you can manually give the ATP as appropriate. Along with that, if patient is having VT storm, always put an external defibrillator pad immediately on it. So many a time you can see that ICD therapy is unsuccessful. However, an external shock can be successful to terminate the VT. Then if you should ask your programmer guy to come, then reprogram the ICD. Look to the ECGM. Just ask him whether it looks an appropriate shock or inappropriate shock. Inappropriate shock can happen due to n number of reasons, like oversensing of anything, some electric signals, some lead fractures, coming into any magnetic field due to any reason. And if possible, you should program your ICD like to prevent ICD shock. You just maximize the number of ATPs. So many of times I've seen that ATPs numbers have been kept low, and just even one ATP fails, the device delivers shock. So we should understand that around 70 to 80% of our VTs can be terminated just by the ATP, and they will not need shocks. However, in some conditions, especially in fast VT, even your ICD can become pro-arrhythmic. So for example, you are VT happening at a rate of 200 and you try a burst pacing in that. So it will convert that VT into VF. So that point you also have to take care. Now coming to the basics of the medical management. So first you have to decide how the risk of the patient is. Like, it's a low risk patient, means patient has an ICD, arrhythmias are easily terminated by the ATP, few episodes, no history of antiarrhythmic drug, start them on drug therapies. So always prefer propranolol in this condition because it's non-cardioselective and has a good CNS penetration. Start them on amiodarone IV followed by oral loading, and consider a basic sedative like a benzodiazepine. However, if the patient is a high-risk patient with like recurrent VT, unstable VTs, not able to terminate by ATPs, already on amiodarone, then you have to add on something. Like, then the options comes like IV beta blocker, prefer an esmolol, so you can monitor the BP fastly, and patient is in heart failure can tolerate these esmolol better than metoprolol. Add a lidocaine, then add a second sedative like a dexmedetomidine, and then you evaluate them whether they is successful or not. Then you have to add the rescue therapies, which will be stellate ganglion block, which I will discuss later on. IV proconamide not available. Consider GA, deep GA, and even intubation. And refer this patient to your electrophysiology colleague, to the centers who can perform VT ablation. And even then, if VT ablation is not successful, then this patient can be considered for heart transplant and LVAD. Along with that, you assess the hemodynamic risk. So how low is the BP? If it is just okay, then you can try vasopressors. If it's quite low, you need to put an IVP in them. And if ECMO available at your center, talk with your CT-based guy and provide them ECMO. So basic drugs, as the risk increases and is not functional, is first is amiodarone IV, followed by lidocaine IV. And always try to repeat the bolus of lidocaine after the first bolus, because it has been shown that second bolus is usually needed to prevent VT storm. Coming to the beta blockers in adrenergic blockade, first will be your propranolol, then try to add metoprolol tartrate, not succinate. And if it is not successful, add esmolol IV. Then in the later stage, if still is not successful, you should try stellate ganglion blockade, and I will discuss how to do it. Ranolazine and maxilitine can be tried, but their efficacy is quite low as a standalone drug, and they always need other antiarrhythmic and adrenergic blockade along with them. Then comes the role of VT ablation if all these things are not successful. If this patient had cardiac MRI, on the left, you can see a patient with large inferior wall MI, good big white colored scar in the inferior wall. This is a LAO tilted inferior view of the heart, which you can see the purple is the healthy and the red is the scar, and this is the borderline zone where the VT circuit is. When you did the substrate mapping, as Ankit sir has discussed, you see the delayed activation happening here. The blue and purple is the delayed activation, and this is the place where the diastolic corridor was when the VT was induced. This is the landmark trial published in NEGM, which basically stand on the authority of ablation rather than escalation of antiarrhythmic drug. For example, a patient comes with VT storm, recurrent shocks. So the options with you are, if patient is already on amiodarone, you can escalate the amiodarone, you can add maxilitine. So it was seen in this trial that primary outcome, which was composite of all-cause mortality, recurrent ICD shocks in next 24 hours, ablation was superior over escalation of antiarrhythmic drug. So as you can see, the VT ablation has been proven in big RCTs to be quite effective in VT storm if done at the proper centers. Then the few words about mechanical cardio support. So mechanical supplementary support is quite needed during VT ablation, especially in VT storm, which can be either in the form of IBP, which is available at your center. Impella, as we all know, that is easily available in our country. Tandem heart requires transseptal access, is not available usually. And finally, even an ECMO can be tried, and these patients can be then taken for VT ablation to support VT ablation. So few words about stellate ganglion blockade. So the Simon Sevastano from Italy has done a lot of work on this, and you should definitely read this paper. So it's basically it's just look after the autonomic dysregulation which happens in VT storm basically. So he proposed this anterior approach, which was described in Murray et al. Rather than this ultrasound guided lateral approach, interscalene approach, which is also known as. He says that we don't need just anything. You have to first identify the C6 vertebra and chagismate tubercle, which is in the front of it. Displace it from your left hand and put a needle here and go directly deep inside till you reach the bone. And this is the sympathetic trunk. Reach to this bone, pull your needle back, insert the BP cane here, and look for the ptosis, anhydrosis, and meiosis happening on the left side. And in this paper, which is published in Europe, in which he clearly showed the role of this left stellate ganglion blockade in patient with drug refractory VT storm. 11 cases needed 18 procedure. He did only left-sided stellate ganglion blood, no fluoro, no echo, just anatomical approach done by the cardiologist. Even during the CPR, no complication were noted in long-term follow-up. And you can see here on the right, the risk of ventricular arrhythmias after 24 hours was quite low. So left stellate ganglion blockade can be safely done, and it's quite useful in patient with refractory VT storm. Few words about stereotactic body radiotherapy, basically which is radio ablation. This was a paper published 5 years ago in NEGM in which they used just 5 patients. For example, you can understand a case series of 5 patients getting published in NEGM is a big thing, because actually it was a big thing doing cardiac rehabilitation ablation in patient with refractory VT storm. So, but over the time, in the last 5 years, it has been seen that it's not as quite as effective, and in initial few months, there's quite a VT recurrence due to inflammation happening due to radiation. And finally, after all of this, getting a VT ablation, radio stellate ganglion blockade, patient is doing fine, then you should definitely evaluate them from advanced heart failure. If it is an advanced heart failure, you should uptitrate their goal-directed medical therapy. Consider them for heart transplantation. And in US, if you have VT storm and you are in the list of heart transplant, you will become the topmost priority. LVAD can be tried, but as we all know that those cannulas which we put in left ventricles are quite arrhythmogenic. And if they develop VT storm with LVAD, because they don't have a right ventricular LVAD, they develop right ventricular dysfunction and become quite sick. So LVAD alone is not helpful, but yeah, LVAD along with VT ablation can be tried. And finally, if we can't do anything, we should consider them from palliative care. So to summarize my talk, if patient has VT storm, means defined as more than 3 sustained VT episode in last 24 hours, always ask your programmer to come if he is an ICD. Always put external defibrillator pads, do an hemodynamic assessment, do an urgent echo, look for the triggers, do one lab analysis. If indicated, coronary angiography. Pain ESD score is basically a score done prior to VT ablation. Optimize the ICD setting as I have discussed. Then start your antiarrhythmic drug therapy in a step-based approach. Consider deeper sedations, anti-arrhythmic therapy, hemodynamic support according to the hemodynamics. If possible, can do cardiac MR after VT treatment and catheter ablation as indicated. If successful, consider GDMT, and if unsuccessful, consider for transplantation. So coming to the first case, which was a case of a structural heart disease, but having likely an idiopathic VT. We took him to the lab because he was in an incessant VT storm, and we mapped this VT in the moderator band subtle aspect. This is the RAO view. The pink means the earliest signal which was seen, and this is the LAO view in which the moderator band is like this. And we don't have an ICE, so we did a transthoracic echo to move our catheter and confirm that this was located on the septal insertion of the moderator band. And with a good signal, which was 30 milliseconds ahead in the QS complex, we gave the burn. And as you can see here, the BT terminated and the patient came back in the sinus rhythm. This patient later on underwent ASD device closure. So to conclude, VT storm is a heart rhythm emergency with a quite high risk of morbidity and mortality, and it definitely requires a multidisciplinary team approach with an electrophysiologist, with a critical care specialist, with your anesthesia friends, and should be referred to an electrophysiology center if situated nearby for the proper management. Usually develops in patient with LV dysfunction, but can happen in patient without structural heart disease, as shown in the case. And these patients usually have an ICD, but ICD programming can be quite helpful. Use drugs properly, start with amiodarone, then lignocaine. Along with that, start beta blockers, sedation and angiolysis according to the clinical presentation, and should be a stepped care approach. Many patients do require catheter ablation, and it's definitely helpful as shown in the RCTs. And hemodynamic support is usually required in quite sick patients, which can vary in the form of IVP or Impella or ECMO. Thank you.
Thanks, Anunay. Again, great, because this whole seminar has been wonderful in the sense of having covered different aspects of VT from ECG to a VT storm. So nothing is left. But for the PGs, I must say that just like you can't read a chapter of Braunwald and have mastered it in one reading, similarly, this seminar would require that you visit it on the website. You again would be more stimulated and understand better when you read through your Braunwalds, and you must do that to gather more. So I'm going to let Deep have a very short discussion with Anunay, maybe something, or offer his own comments, and we'll end up with a comment from each of the faculty and moderators. So Deep, you can have some observations on this.
Yeah, I think Anuna has covered very well the topic of the approach to, or how do you manage VT storm. I have nothing more to add. I will just summarize. So whenever you have a patient of VT storm, he did mention what you do with an ICD shocks. So you place a magnet, have the patient on cardiac monitor, and then Then you give amiodarone. That's the reflex drug for all of us. We do give load with amiodarone immediately. We say load with amiodarone. And if it does not subside, then we use lignocaine as an add-on agent. And then another useful agent that we usually give is propranolol, especially in the setting of VT storm. Propranolol suppresses the sympathetic system overall and can also help in bringing down, in the absence of esmolol, propranolol can be a useful thing, overall suppression. And then sedation, general anesthesia, dexmed infusion. And I talked about the dexmed. It's a very useful drug with not much of hemodynamic problems. So these are the things that people or the physicians can do when they do not even have a cath lab access. Amiodarone, lignocaine, propranolol, sedation, general anesthesia, dexmed infusion, all of these can be done even if you don't have a cath lab. And then if you have a cath lab access, then obviously you would like to rule out coronary artery disease. You have also an option of overdrive pacing. You can, if it's especially a sustained monomorphic VT that you're having, or if a brady-dependent long QT or a long QT that is causing polymorphic VTs, you could prefer to have a temporary pacing wire and pace at 80 to 100 beats per minute, depending on how the patient tolerates. So temporary pacing wire, ruling out coronary artery disease, all can be useful once you have a cath lab access. And
Deep,
then,
just to interpret, two uses here, right? Temporary pacing. One is to terminate the VT,
yes,
slow hemodynamically stable monomorphic VT, and other is to prevent a VT, right? In a Brady-related VT, you said, right?
exactly.
Okay, please carry on. Yeah.
So if you have a ongoing monomorphic VT, you can use a TPI or a temporary pacing to overdrive, terminate the VT, and also keep the pacing at a higher rate so that you don't get another VT. And if you have long QT intervals, again, overdrive pacing will help to keep the QT shorter, and especially a Brady-dependent VT, and then it would, again, prevent further episodes. So if you have a cath lab access, ruling out coronaries and then problems, and then this temporary pacing wire can help. And then if you have an anesthetist, well and good, or you can, if you know the technique of stellate ganglion block, it really helps again, the left, especially the left side. I've seen a few centers where they do the right side stellate ganglion, but we usually tell them as a cardiologist, it's preferable because much of the sympathetic innervation comes from the left ganglion. So if at all you need to do one stellate ganglion block, it has to be the left-sided stellate ganglion block. And that can be done again, ultrasound guided approach. Few of them are trained to do fluoroscopic, but then ultrasound guided is also bedside. These are all bedside approaches that can be used. Of course, you have an electrophysiologist, and he would really help to take the patient for a quick ablation. And VT storm ablations are actually, if the patient is hemodynamically stable, one of the easier kind of ablations because you know exactly what you do. A little bit of here and there, the VT storm usually responds very well. But then in the absence of an electrophysiologist, you still have a lot of options that you can try and to keep the patient stable and then have the necessary electrophysiologist or the consultation comment. Nothing more.
Sure. Thanks, Deep. So I'll request one comment each from Professor Isar, followed by Ankit and then Anunay, and let Deepak have the last word on this seminar. Professor Isar, if you're there, please come in and chip in your comment. Maybe we are, he's not around. Ankit, can you offer a short comment and then Anunay maybe?
Yes, sir. So I think the goal of the VT ablation should be to reduces the burden of the VT, and it's not a curative procedure. That should be understand. And as the disease is progressing and so we can have another circuits and going on. The purpose is to reduce the morbidity and reduces the ICD shocks, and appropriate time referral is important because the earlier the VT ablation is done, it is better to reduces the toxicity of the antiarrhythmic drugs that patients need to take to suppress the VT and unnecessary ICD shocks. So the purpose should be to reduce the burden and not a cure.
Yeah, Anunay?
And one thing, even Dr. Anand has asked, I would especially want to highlight that patient presents with monomorph VT and a VT storm. The role of angio is just even the presence of history suggests of an ischemia. You document some ST elevation somewhere. But it's clearly shown in a data published recently in Circulation Revive ECS2 trial there's no benefit of revascularizing this patient. So nothing is going to happen to if a patient has monomorphic VT and it's critical coronary artery disease, even blocked artery. You think that you will fix that CTO and VT will go away because this VT is happening due to scar. So ischemic VT are usually polymorphic. Even if you find like after 3 days of MI, patient is having a VT and it is monomorphic due to a scar, it's not due to an ischemia. So it is actually very clear that revascularizing an ischemic artery will not decrease the recurrence of VT. These patients needs an ICD or ablation. If ICD can't affording an ablation and then having recurrent shocks after an ICD, then an ablation.
That's crystal clear. Deepak, would you want to end this wonderful seminar with some nice comments? Apt comments here.
Thank you, sir. In summary, AVR-AVL negative, outflow tract VT. AVR-AVL not negative, VT coming from elsewhere. The slope of the QRS similar to the slope of sinus rhythm with normal heart, likely fascicular involvement in VT is present. Keep your eyes open for fascicular VT, typical Belhassen. And as Anunay said, monomorphic VT with the absence of the two above features is scar VT, may or may not be accompanied by obvious structural heart disease. History of ischemic heart disease in the past supports monomorphic VT. And finally, hemodynamic stability is the key to management of wide complex tachycardia. All of this can happen later. Thank you.
Thanks. Great, Deepak. I think we always allow a little bit of laxity in the times to which we keep because this is meant for the cardiology postgraduates and that has been the intention. And so we are, I think all of us are happy to spend 10-15 minutes extra to get our points through. Thanks the VMMC team, Professor Isar, Ankit, Anunay, especially for gathering them on this podium and making a wonderful session as a whole. And let me repeat it one more time as I've done before in this, that this will come up on the IHRS website as some of the previous seminars, and you can always visit them peacefully and at leisure and go through those concepts, come back to the books and read a bit, and I hope it helps in your exit exams. Thank you very much, the VMMC team, for doing this for the IHRS. Thanks very much. Bye-bye. We'll again meet next week on the first Sunday. Thank you.
Thank you, Ashish sir. Thank you so much for the
Thanks.
Thank you.
Thank you, Deep. Thank you, Deepak sir.
Thank you.
Thank you, sir.
Yes. Bye-bye.
Bye.